Morning, guys. Today our topic is they give me few viral infections: measles, mumps, rubella, and infectious mononucleosis. These are the few of common viral infections. Any infections where you have to read in under few headings. Any infection, first you have to talk about etiology. Etiology is like what causes that infection. Etiological, like what is the main, like what organism is causing that infection, that comes under etiology. And then epidemiology. Epidemiology is like which age group of people are involved, how they are involved, like what are the incidence, prevalence of the disease, and what demographic spread it has got. Everything comes under epidemiology, like which areas of the world it is spread. All that comes under epidemiology. And then we have to talk about transmission. Transmission is how it transmits from one person to other person. All these infectious diseases, they transmit to two different ways. For example, if you take dengue, it is transmitted by mosquitoes. But if you say recently what is happening, COVID, it is transmitted by droplet transmission. So different infections have different modes of transmission. And then once the virus enters the body, it causes few damages in the body, like pathology. It causes some kind of destruction in the body. That is pathology. And then pathogenesis. The process of pathology is known as pathogenesis, like the mode of events, one after another, what all it causes that comes under pathogenesis. Then all these pathogenesis together, they manifest as clinical manifestations in the infected individual. So we talk about clinical manifestations of the disease. Then we talk about diagnosis, how we diagnose the disease. There are a lot of infections, a lot of diseases have different clinical manifestations, different pathogenesis and different transmission, everything. Like how we differentiate whether this is coronavirus or not, whether this is dengue or not, like how we differentiate, that is diagnosis. And then differential diagnosis. Many of these infections can mimic each other. Like we may get confused between, like all as universally have same clinical features of fever, throat pain, running nose. All these things are common in all these viral infections, most of these viral infections. So how do we differentiate between these two? Those are like differential diagnosis. Like what all cause similar complaints are known as differential diagnosis. And then complications. What are the complications of these infections? And then treatment, modes of treatment. What are the treatment we give for these infections? And prevention. These are like what are the steps we take to prevent these infections? These are all like any infection you take, we have to read, we have to present the infection, or we have to read the infection in this following headings: etiology, epidemiology, transmission, pathology, pathogenesis, clinical manifestation, diagnosis, differential diagnosis, complication, treatment, and prevention. These should be the headings. Firstly, we'll start with our first virus that is given for today is measles. Measles is one of the oldest infections and most common throughout the world before vaccines. And the incidence has come down drastically after vaccination, but now and then there are epidemics taking place everywhere in the world. Whenever the level of immunity or amount of immunization comes down, measles epidemic comes, and then gradually, with again increase in vaccination, everything it wanes off. Finally, firstly, like measles is a disease caused by measles virus. What is virus? This virus is a single-stranded lipid envelope RNA virus. It's an RNA virus. It has got like single-stranded RNA virus with lipid envelope. It belongs to family Paramyxoviridae and genus Morbillivirus. And after etiology, then we talk about transmission. How this virus transmits from one person to another person. Here, measles, the only host for measles is humans. So generally, it transmits from human to human. There is no intermittent host for measles. So transmission, how it happens? Transmission happens through respiratory tract or conjunctiva. When the infected person's saliva, it like falls on the susceptible person's respiratory system. I mean respiratory tract. I mean nose and mouth or wherever. Or on the conjunctiva, it can induce illness in the susceptible individual. So generally, patient once he gets infected, he's infectious to others for 3 days before the development of rash to 4 to 6 days after the onset of the rash. Today we'll be talking about our 4 viruses. All 4 of them causes the rash. So that universally they have rash in them. So We call them exanthematous diseases. So all this will have rash. So here, before development of rash itself, the infected individual will be infectious with others. It will be shedding virus around. And measles is very contagious. It has 90% chances of 90% of chances to catch virus from an infected individual. If you're exposed to a measles infected individual, there's 90% of chance that you acquire measles disease. So it is highly contagious disease, and the virus is viable for as long as 1 hour in suspended air. Like if as a person, infected person who comes enters into this room, he sneezes or coughs, and then he moves out of the room, but still the virus is suspended in the air for about 1 hour. It is viable in the suspended aerosols for 1 hour in the room, and it is capable of infecting others, whoever enters into the room after him, especially in theaters, public like buses and all that. The passenger who has infected, who has measles infection would have got down at some other stop, but like the people who enters into the bus after him, they may get infected. So it is highly contagious. And then coming about pathology, what destruction it causes in the human body? It causes necrosis of the epithelial tract, respiratory tract epithelium. Generally, upper respiratory tract epithelium. It causes necrosis in the upper respiratory tract epithelium. This leads to lymphocytic infiltration into the upper respiratory tract. Then it can cause small vessel vasculitis on skin and mucous membrane. Small vessels, the vasculitis, that inflammation of the small vessels can happen over the skin and mucosa. That actually these things causes the rash in this measles. And once the infected cells they fuse together to form a giant cell. This is known as Warthin-Finkelday giant cell. It can have up to 100 nuclei. Means the 100 cells which are infected in surrounding, they fuse and they form a one giant cell. And then pathogenesis. Pathogenesis, what happens once the virus enters into human body through respiratory tract or conjunctiva, it goes to the regional lymph nodes. Regional lymph nodes of that part, like wherever, like it is going for upper respiratory tract, it will go to some cervical lymph nodes in the upper respiratory, like cervical lymph nodes or hospital lymph nodes, whatever it is. It enters the lymph nodes. There they multiply and they release the virus into the blood. That is known as primary viremia. After primary viremia, this whatever virus enters into the reticuloendothelial system. In our body, reticuloendothelial system consists of adenoids and then what liver, spleen, all this comes into reticuloendothelial system. So it involves this system, and then the secondary viremia happens. From there, the large amount of virus again comes out of this reticuloendothelial system. That's when the patient starts showing the symptoms. Like whatever happens when the wing of virus enters the human body to secondary viremia, this period is known as incubation period. The patient will be apparently normal during this incubation period. Like he won't have any symptoms. He won't show any symptoms during this period. He will be like a normal, healthy individual. After secondary viremia, the patient, like the infected individual, starts showing some symptoms. What happens is after secondary viremia, the virus enters into the body. It causes few changes, few fever, viral prodrome. It causes viral prodrome, and along with this, virus start entering the body surface and epithelium of the like oral epithelium and other things. It causes necrosis, oral mucosa and necrosis, and giant cell formation in the body tissue. The giant cell, whatever I told you before, that Warthin-Finkelday giant cells are like formed. This is like prodrome. During the prodrome, this happens. After prodrome, the patient develops with this necrosis. Patient develops rash, and with the onset of rash, their antibody production begins. This is exanthematous period, and then once the antibodies are produced, viral replication comes down, and symptom also begins to subside. This is the stages of pathogenesis. Actually, from entry of the, like virus entry into the body to secondary viremia, this is generally incubation period. So that I put on yellow color, and then once it is released into secondary viremia, released into blood, it becomes into prodrome, viral prodrome kind of thing. And after that, development of rash, these things comes, and the development of rash comes into exanthematous period, exanthematous phase, and after that there will be recovery phase. Recovery phase, like all these viral replication symptoms subside during recovery phase. And clinical manifestations. Coming to clinical manifestation, as I told you, there are 4 phases of clinical manifestation in measles. First is incubation period. Initially, it takes 8 to 12 days for the virus to enter to cause symptoms. Once the virus enters, it takes time to cause symptoms. That is incubation period. As I said, during this period, the patient will be apparently normal. Like he may not be normal, but he looks healthy. You won't have any symptoms, signs and symptoms during this period. Then comes viral prodrome. During viral prodrome, initially, here it starts as mild fever, and then the patient develops conjunctiva with photophobia, coryza, and prominent cough. In measles, the important thing is prominent cough that differentiates it from other similar infections like measles, mumps, rubella, whatever infection it is. Here, the cough is very prominent compared to other viral illness, so that differentiates from other infections. And after this, viral prodrome, they can have increased fever and Koplik spots. Koplik spots is a pathognomic sign here for measles. Like nowhere else it happens except in measles. Koplik spots are ananthema. Ananthema is the rash in the mucous membrane is an ananthema. It develops 1 to 4 days prior to onset of rash on the skin. This Koplik spots. What are the Koplik spots? There's an image here. I don't know if you can appreciate or not. Here that be like red rash with silver kind of bluish white top. This is Koplik spots. Generally, we see in the oral mucosa opposite to premolars on the cheeks, actually on the inner side of the cheeks, we see Koplik spots. And after this prodrome, the patient will have xanthematous phase. Here, xanthematous, the rash begins with forehead along the hairline. Along the hairline, this patient will start having a rash, and it can start behind ear or upper neck. From there, it progresses downwards towards torso and extremities. We call this as centrifugal transmission of rash, centrifugal mode of spread of rash. And then from torso extremities, it can end up with palms and soles. Generally, this rash fades in 7 days, the same way as it progresses. Like from above downwards, like first it disappears on the forehead or whatever neck and ear. From then torso and extremities, and finally palms and soles, the rash will disappear. While the rash disappears, it leaves fine discoloration of skin. And then recovery phase, like where the symptoms, everything regresses gradually. That is recovery phase. This is Koplik spots. And this maculopapular rash of measles on the skin. As I said, it starts with the forehead, around the hairline, and behind the ear and upper neck. Then gradually it progresses towards the like spreads centrifugally to torso and extremities, and then palms and soles. And same way it disappears also from above down. And diagnosis. Most of the measles, the mainstay of diagnosing measles is by clinical presentation and examination. Like by whatever history that the patient gives and examination, we can diagnose measles. But if you have any other further doubts, like in the later stage of measles, when the rash develops, when we mimic the other infections, so that time we sometimes to diagnose we need IgM measles, it can be done. And viral isolation is rarely done. It's not usually recommended unless like in some research purpose or something they do viral isolation, but usually they don't do viral isolation. And if you see blood counts during this period of infection, patient will have leukopenia. Leukopenia, the total WBC count comes down. Both lymphocytes and neutrophils, both numbers comes down. More of lymphocytopenia. Lymphocytes fall is more than neutrophil side. Neutrocytes, neutropenia. They can have absolute neutropenia. And normal acute phase reactants like CRP and ESR can be below the normal, like can be normal in this. Can be normal in these patients. Differential diagnosis. Measles can have similar presentation can be seen with rubella, adenovirus, enterovirus, EBV. And mycoplasma pneumonia and group A streptococcus can also have similar rash. So it is difficult in later phase of the disease, it's very difficult to differentiate from other diseases. like other viral infection, like rubella adenovirus. And Kawasaki can also have similar rash, but in Kawasaki disease there is no cough. Whereas in measles, the cough is the main prominent thing in measles. In Kawasaki, the cough is very less. And few drug reactions also can mimic the measles rash. But generally, drug reactions are fixed drug reactions mostly. Like they, every time you use the drug, the rash appears at the same side of the body. And then complications. Most common complication of measles is acute otitis media. Acute otitis media and diarrhea, vomiting are also common. Pneumonia is the most common cause of death in measles, and other symptoms like croup, tracheitis, and bronchitis. Most of this croup, tracheitis, bronchitis, they need humidified oxygen, and then rarely, if it is very severe, the patient may need intubation also, like ventilation also. Patient can have encephalitis. Encephalitis here it is mostly immune mediated. That is, like the virus itself doesn't cause encephalitis here. Once the virus subsides, viral infection subsides, the antibodies produced against viruses, they initiate a immune reaction in the body. Like most of the time, the encephalitis, the virus would have been out of the body by the time the encephalitis developed, but it's just immune mediated. And black measles or hemorrhagic measles. There's one more complication where with measles there is a hemolysis of the hemolysis taking place. Like the RBCs will be lysed, so the patient can have like hematuria and other things can be there, and anemia, severe anemia, acute anemia, and sudden pallor, sudden development of pallor, all these things. This is black measles. It's kind of rare, but it can happen. And during pregnancy, especially during first trimester of pregnancy, if the mother gets infected with measles, there are high chances of stillbirths or like congenital malformation in children. Up to 3% of the children whose mothers got infected with measles can have congenital malformations. And then one serious complication, very serious complication is SSPA, subacute sclerosing panencephalitis. This is a like very deadly, like almost all children who develop this SSPE end up with death. This actually develops after a normal period, like mid 7 to 15 years after the viral infection. The children will be very normal for the period of 7 to 15 years. Then they start showing behavioral changes initially, and then involuntary movements like myoclonus and all that. Then they will be showing like other choreoathetosis, and then finally there will be loss of consciousness, coma, and then finally death. Respiratory system and other system centers in the brain are affected, so there will be death, SSP. But it is very kind of rare complication, but it can happen. And then treatment. Most of the main way of treatment is supportive. Supportive in the sense like symptomatic treatment, like the child has fever, we give antipyretics. For any dehydration, we give hydration, like we maintain hydration. Any difficulty in breathing, we give humidified oxygen. And if so necessary, we may need to ventilate, but rarely, very rarely it is required. And then most common important thing is vitamin A. This measles is associated with vitamin A deficiency, or like patient may be having subclinical vitamin A deficiency, which is not like per se have any features of vitamin A. But with development of measles, they show the drastic fall in the vitamin A levels. So most of these children, they are given vitamin A. Generally 2 lakh units for 2 days. For children about 12 months is given, usually given. But if children is less than 12 months, 6 to 12 months, we give 1 lakh international units for 2 days. If children is less than 6 months, we give 50,000 international units for 2 days. For 2 days. So vitamin A plays an important role in this thing. I think vitamin A decreases morbidity and mortality associated with measles. And one important thing is vitamin A is given along with measles vaccine also. Around 9th month of age, children gets MMR vaccine or measles vaccine along with vitamin A. And then vaccination. Prevention is by vaccination. Mostly we can prevent this. It is a vaccine preventable disease, measles. So we vaccinated children. Before it used to be measles vaccine. Till recently it was measles vaccine in our national immunization program. Now they recently changed to MR. And in private practice, we give mostly MMR. MMR is measles, mumps, and rubella. Government supplies only measles and rubella here. Generally, according to WHO, they do like they advise 2 doses of measles vaccine after 12 months of age. Before 12 months of age, they say like it won't build up so much of immunity. So after 12 months of age, children need 2 doses around like according to like Western literature, it is mostly 12 to 15 months they give first dose, second dose around 4 to 6 years they give second dose. But in endemic areas, the children even before 12 months they get infected with measles. So here we bring down up to 9 months. 9 months also we give. Once the child has completed 9 months of age, we give first dose of measles, and followed by according to National Immunization Program, there is one more dose at 15 to like 14 to 16 months. But according to IAP, we give third dose also around 4 to 6 years. We give third dose. So in India, usually we give 3 doses of measles vaccine. Measles or MMR. We choose any of them, but mostly advisable is MMR. And post prophylaxis, vaccine can be used even for post prophylaxis. Like if someone is exposed to a measles susceptible person, who is susceptible, like who has never got measles and is highly at risk, like children less than 6 months of age, or pregnant women, or immunocompromised person, if they are exposed to a infected individual, they can have vaccine within 72 hours of exposure. So that vaccine provides immunity for them if they are given within 72 hours of exposure. And if it is beyond that, we can give immunoglobulins. Up to 6 days after exposure, we can give immunoglobulins. Generally, what I was said, like children less than 6 months of age, pregnant women, and immunocompromised persons can get this vaccine. The immunoglobulins are vaccine. Post prophylaxis. And then coming to our next viral infection, rubella. Rubella is also known as German measles. First one, what is measles? This is German measles or 3-day measles. You know 3-day because the here rash lasts only for 3 days. So we call it as 3-day measles. Generally measles it stays for 7 days or more, but here it is only 3 days. It is a mild disease in children. It can cause severe disease and complication in adults. In children it is very mild, but it can cause little severe disease and along with complications in adults that we have to. The main clinical implication of rubella is congenital rubella syndrome. See, otherwise rubella is a very mild disease, along with other very difficult to differentiate from other viral infections. The main importance of clinical implication is transplacental transmission. Like if mother gets rubella, she transmits rubella to the fetus. If the fetus gets rubella, there are high chances of fetus getting congenital rubella syndrome. Like there are a lot of things, like from head to toe, it can involve anything in rubella syndrome. The newborn is the fetus is involved here. So that is a major implication. The main role of rubella, whatever prevention treatment, studying about rubella is congenital rubella syndrome. Etiology. Actually, rubella virus, it belongs to Tonga virus family and rubivirus genus. It is a single virus in rubivirus genus actually. There is no other virus in here. It is a single standard RNA virus with lipid envelope. Human is its only host. There is no intermediate host anything. It's transmitted from human to human. Epidemiology, in pre-vaccine era, before the vaccine of whatever rubella developed, major epidemics used to happen every 6 to 9 years, with small peaks between 3 to 4 years. Common age of people affected are preschool and school children are most commonly affected in pre-vaccine era. Whatever I told, like every 9 years, the rubella epidemic used to happen, and a lot of this congenital rubella syndrome babies fetus used to be born, and in between 3 to 4 years, there used to be small peaks of this rubella. And then coming to pathology, actually nothing much is known about rubella's pathology. Most of the whatever pathology we know, it's got by like post-mortem studying, like whatever congenital rubella syndrome babies, like most of stillbirths and miscarriages. By studying the pathologists, they found out the whatever the pathology they know. It is a non-specific lymphoreticular infiltration happens in rubella. Actually, here the main pathology is often congenital rubella syndrome, CRS. CRS is congenital rubella syndrome. It is often severe and involves every organ system in the body of a fetus. From cardiac, PDA, like patent ductus arteriosus. It can lead to patent ductus arteriosus, pulmonary artery stenosis, ventricular septal defects, myocarditis. In CNS, it can cause chronic meningitis and parenchymal necrosis. In eye, microphthalmia, cataract, glaucoma, and retinopathy can happen. Especially in rubella retinopathy, we say salt and pepper retinopathy. Ear, it can cause cochlear hemorrhage and nerve deafness. And RS is interstitial pneumonia on the respiratory system. And it can cause microcephaly. It can involve like whatever organ you name it, it can involve all of the organs. Pathogenesis. What actually happens in pathogenesis is the virus replicates in the respiratory epithelium. Once the virus enters into the body, it replicates in the respiratory epithelium. Then it enters into the regional lymph nodes, and then happens the viremia. Viremia is like the viral load is released into the blood. This happens around 10 to 17 days after infection. Generally, metal infection during early pregnancy caused most severe and widespread defects. Generally, otherwise you need not worry about rubella much, but except for metal infection. Metal infections are very severe, like not in the mother, but it they transmit to the fetus, transplacental transmission, and affect the fetus. It can cause severe and widespread defects in the fetus. Generally, just time of infection, infection and risk of congenital effects. There's a table here. See, if the mother gets infected before 11 weeks of gestation, there's a 90% of chance of fetus having congenital defects. 11 to 12 weeks, it's 30%. 13 to 14 weeks, is 11%. And 15 to 16, again, there is a likely small rise, that is 24%. Generally, after metal infection of 16 weeks of gestation, less likely to have any congenital defects. Pathogenesis. Once the fetus is once the fetus is infected in early gestation, virus persists in fetal tissue until well beyond delivery, and possibility of ongoing tissue damage and reactivation, mostly in the brain, takes place. Like when the baby fetus is infected, they carry this virus well beyond their birth. Like inside the womb, that whatever restriction that would have happened, after birth also the baby carries the virus, and then there would have been there can be any damages and reactivation can happen. Clinical features. Clinical features are like usually mild and not easily distinguished from other viral infections. Generally, this is very mild infection. Then viral prodrome can have like mild fever, sore throat, eye, headache, eye pain, red eye, headache after incubation period of 14 to 21 days. In children, it can manifest as a rash beginning with face and neck and then spreading centrifugally to torso and extremities. Like same as measles, here also rash starts at face and neck and then it spreads to torso and extremities. But usually here the rash lasts only for 3 days. There in measles it is for 7 days. In rubella it is only for 3 days, and they go without leaving any disclamation. There is no disclamation here. In rubella, in measles we see disclamation. And throat examination. If you examine throat of these children during rash period, we can see tiny rose-colored lesions. Forth-Meyer spots, we say. Forth-Meyer spots, we call them. Or they can have petechial hemorrhages on soft palate. This is a rubella rash on the face of the baby. Generally, the triad of rubella, we call it as cataract, cardiac abnormalities, and deafness. Initially, rubella syndrome, congenital rubella syndrome was first observed by an ophthalmologist. He used to observe the babies, most of the newborns with cataract, they have associated cardiac abnormalities. So he attributed this disorder to rubella, and most of these children on investigation further, they found it to be true. And on further investigation, they found they have deafness also, most of these involved children. So these are the classic triad of rubella: cataract, cardiac abnormality, and deafness. And they can have other features along with that, whatever I said, even lungs can affect, kidneys, anything, any organ can affect. But mostly these three are the main thing. Other things are growth retardation, IUGR. These congenital rubella syndrome babies can have IUGR. They can have rash, hepatosplenomegaly, jaundice, meningoencephalitis. They can have other mental retardation, it's affected the brain parenchyma also, necrosis causes necrosis of brain parenchyma also, so it can have microcephaly and mental retardation. And diagnosis mostly by clinical examination and other things. But if you see any postnatal infection of rubella, postnatally is after birth. The only worry thing in rubella is antenatal birth, when the baby, fetus gets infected within mother's womb, that is the time of worry. Otherwise, postnatal we need not worry much. But if you see during the time, they can have leukopenia, neutropenia, and mild thrombocytopenia, which are transient and recover on their own. In pregnant women, if you're suspecting rubella infection, we can do IgM enzyme like IgM enzyme immunosorbent assay. Most of them can give positive. Like the diagnosis depends upon the titers, amount of titers of IgM. In infants, we do IgM capture assay because like these infants would have got IgG from mother. This IgG causes like this IgM enzyme immunosorbent assay cannot be done with so much of IgG. They can give false negative. So we'll go for IgM capture assay. Or like better things are reverse transcriptase PCR or viral culture. We do for this infants to diagnose to document congenital rubella syndrome in infants. Differential diagnosis, again, differential diagnosis measles, first differential measles, but here complex spots with a pathognomic for measles are not here in rubella, and short duration. In measles, we know rash lasts for 7 days. Here, it is only for 3 days in rubella. So, it's like we can rule out measles from rubella. And other viruses can have similar rash as adenovirus, parvovirus, B19, EBV, enterovirus, mycoplasma, pneumonia. All this can have similar rash and like they can be differential diagnosis. Complications. Yes, with postnatal infection, not much of a complications. They can have transient thrombocytopenia, arthritis, encephalitis can be seen, but with these are self-limiting. The patient recovers very well from this thing. Rarely, post-rubella panencephalitis syndrome can develop in children. It is similar to SSP, like subacute sclerosing panencephalitis, which we've seen in measles. They can have similar. They can have post-rubella panencephalitis, which is a deadly thing, deadly complication. Patient generally usually dies in 2 to 5 years. The child usually dies in 2 to 5 years. Then our main worrying thing is congenital rubella syndrome. Here, basic generally presents with microcephaly, cataract, congenital heart abnormalities, nerve deafness, IUGS, salt and pepper retinopathy. They can have interstitial pneumonitis, so they can die of like difficulty in breathing. And late onset, these congenital rubella syndrome can have, I mean, these children with congenital rubella syndrome, they can have late onset diabetes mellitus. I mean, they can have like early diabetes mellitus in life, and thyroid dysfunction they can develop. Glaucoma and visual abnormalities with retinopathy can be seen in this children. Treatment, there's no specific treatment here except for the supportive care. Supportive care in the forms of like whatever antipyretics and others we give. But once the child develops congenital rubella syndrome, only supportive care. There's nothing much. Like it needs to be a multidisciplinary approach for congenital rubella syndrome. We know like from eye, ear, heart, it can involve any organ. So we have to be very vigilant for all these things. Sometimes congenital rubella syndrome, the symptoms appears little later. I mean, like at presentation, child may not have all of the symptoms. So we have to follow up them to see like whether in the process they can develop retinopathy or diabetic mellitus, everything. So regular follow-up is necessary for the children, and a multidisciplinary approach for the children. Like most of it involves pediatric cardiologist, ophthalmologist, and then ENT surgeon. Everything it involves a lot of people. So that is multidisciplinary. They need vocational training also, and then language therapy and most of things. These children are mostly mentally retarded, so they need a lot of support. And prognosis, if it's a postnatal infection after birth, if child is getting infected, very good prognosis. There is no complications. If complications are there also, the self-limiting and child recovers very well. But if it is a congenital, it is a congenital rubella syndrome, then sorry, CRS actually, congenital rubella syndrome, ES I put, is a mistake, spelling mistake. So if it is a congenital rubella syndrome, the outcome is very unfavorable, less favorable. Prevention is by isolating the infected individual for 7 days after a rash, that we can prevent. And in congenital rubella syndrome, infant can excrete virus in respiratory secretion up to 1 year of age. Even in urine and feces also they can secrete. So all these infants with congenital rubella syndrome, serial, whatever called, these cultures, the culture should be done enough respiratory secretion, everything. Once it becomes negative, only then we can take it as negative. Otherwise, if the infant has born of congenital rubella syndrome, they can transmit to other infants surrounding them. So they should be very careful with these infants. And then vaccination, it needs 2 doses after 1 year. Same as measles, Generally in India, we give at 9 months, so we give two doses after that, around 4 and 6 months second dose, and third dose at 4 to 6 years. And post exposure prophylaxis vaccine can be given up to 3 days. Then coming to mumps. Excuse me. And coming to mumps, mumps is also an this is associated with the rash. Mumps is usually caused by mumps virus, belongs to Paramyxoviridae and rubella genus. It is a single standard pleomorphic RNA virus. Pleomorphic is it has got a lot of forms. There is no single form. It varies with encapsulated lipoprotein envelope. Generally, pre-vaccine era, it mostly infected children 5 to 9 years of age. In epidemics, every 4 years. We know in rubella, the epidemic is every 6 to 9 years, but here it is every 4 years epidemic used to happen. Mumps epidemic used to come, most frequently in winters and springs. With vaccination, the infection rates drastically came down in children, but now we see a like new cases coming up in adolescents and young girls around 18 to 24 years. The infection rate is rising, maybe because we're giving vaccine to most of people by 18 to 24 years. I think the immunity, like whatever immunity we are gaining through passive immunity through vaccines, it is waning off and they're showing infections. Transmission by again respiratory droplets. Virus is transmitted by saliva of infected person from 7 days before to as long as 7 days after onset of parotid swelling. Mumps, the main thing is children will have swelling, parotid swelling most commonly. So 7 days before the swelling to 7 days after the swelling, the child can transmit virus. So as the children will be shedding virus before onset of swelling, we don't know the child is anyone like subclinically, even like before getting symptoms only, the child starts spreading the disease. So by isolation, we can't control this virus. So there's no point in isolating here. But pathology, what happens is necrosis of infected cells and leads to lymphocytic infiltration. Pathogenesis was the virus enters into the respiratory epithelium, like epithelium. They multiply there and they're transmitted to lymph nodes. From lymph nodes, again, they multiply there and then viremia, like the viral release into the blood happens. So once the viremia happens, it reaches the target organs or tissue where it causes necrosis of infected cells. Target organs here for mumps is salivary glands, CNS, pancreas, and testis. Most commonly, it is salivary glands primarily. And clinical manifestation, generally after incubation period of 12 to 15 days, the prodrome starts, which lasts for 1 to 2 days, like with mild fever, coryza, and headache can be there, followed by parotid swelling. Main parotid swelling, it can be unilateral initially, and then it becomes bilateral. The other side also becomes swelling, like starts swelling in 70% of the cases, not all, like most of them develop bilateral disease, accompanied with ipsilateral ear pain. Whichever side the parotid swelling is there, that side ear pain can develop. With increasing in parotid swelling, it can obscure angle of jaw. Angle of jaw can be obscured with earlobe lifted upwards and outwards. And redness edema of the stanchion duct can be seen. Generally, parotid swelling peaks for 3 days. 3 days it peaks and gradually subsides over 7 days. And morbidly formed rash can be seen rarely, not much. Around some 30 to 40 children will have this rash. This is the mumps, parotid swelling. You can see parotid is like just before the ear, like posterior part of the cheek, swelling develops. And diagnosis is just mainly based on history of exposure and typical clinical findings. Like salivary gland involvement can be, justified by elevated serum amylase. If you see serum amylase is elevated, that shows that salivary glands are involved. They can have leukopenia. Leukopenia is like decrease in WBC counts with related lymphocytosis. And rarely IgM, IgM for mumps is done. So not measles, the typing mistake. And viral isolation can be done from upper respiratory tract secretions, CSF, or urine during acute illness. And complications. They can have meningitis with or without encephalitis. Nothing much important complication. Most of them resolve normally. Very rarely, some 10 to 20% can lead to deaths, but most of them recover. And then gonadal environment is another important complication of mumps is gonadal environment. Here, arthritis mostly commonly in post-pubertal boys it happens. Then more than pubertal, post-pubertal boys can have arthritis, that is inflammation of testis, can lead to atrophy of testis. Testis can become atrophy, but most of them they won't end up with sterility. When atrophy testis also they'll be somewhat functioning, so they won't have sterility. Most of the times can lead to sterility, but very few. And then ophiritis can rarely occur in post-pubertal females. Like arthritis is more common than ophiritis. And then uncommon complications like conjunctivitis, optic neuritis, pneumonia, nephritis, pancreatitis, and thrombocytopenia can happen. Metal infection with moms during first trimester of pregnancy leads to fetal wastage. That is one important thing. And then supportive treatment. Usually, we usually give antipyretics for pain and fever, and maintaining hydration is important in moms. And prognosis, excellent prognosis. Even with complications, the patient recovers very well. Prevention. Vaccination along with measles and rubella. We give like MMR vaccine. Next is mumps, that is also involved. As I said, we give 3 doses in India. Generally, first dose at 9 months MMR, and then again second dose at 14 to 16 months, and third dose at 4 to 6 years. And one more thing I have to highlight here is MR campaigning that happened in around 2015-16 in India, where the target population is adolescent girls, adolescent girls, and I mean, childbearing age group women are the target there. MR campaign, where, as I said, rubella, it leads to congenital rubella syndrome. The main of MR campaigning is to prevent rubella syndrome. And then measles epidemic, they want to control both rubella and measles epidemic. So they, wherever like throughout India that happened in around 15-16, where all the target population in schools and everywhere, adolescent girls, boys, everyone is targeted, and everyone universally given MR vaccine, like how pulse polio, they given like throughout India, they gave MR campaign. I think every 4 years they have to do it. I think the next MR campaign will come in this year, next year. Maybe because of Corona, it may be delayed later, but there will be one more session of it. Infectious mononucleosis. Our last thing is infectious mononucleosis for today. It is caused by Epstein-Barr virus. Infection mononucleosis is caused by Epstein-Barr virus. Then Epstein-Barr virus, like infection mononucleosis, is also known as glandular fever. Before it involves the glands, so people used to call it glandular fever. Then EBV is Epstein-Barr virus, is a DNA virus belonging to herpes family. Till now we have read about all RNA viruses first 3. This is a DNA virus, and also described as glandular fever. Whatever I say, it derived its name like infectious mononucleosis. The name it got it from mononuclear lymphocytes with atypical appearing lymphocytes that accompany the illness. During this illness, the infected individual can have atypical appearing lymphocytes during this illness. So the name came like infectious mononucleosis. Infectious mononuclear like illness can develop with other viruses like cytomegalovirus, toxoplasma, adenovirus, hepatitis virus, primary HIV, and rubella sometimes can lead to infectious mononucleosis like illness. Epidemiology, EBV infects more than 90% of the world population. Like almost all like people in the world, most of them are most of them will get sometime in their life they get infected by EBV. That EBV is like kind of herpes only, like obviously it belongs to herpes family. Once it affects the body in individual, it stays in the body forever. They can have a remission in between, and asymptomatically they can have reactivation of EBV. Asymptomatically, if the individual is like immunocompetent, they can have asymptomatic reactivation where they will be spreading during the time, like they will be spreading the virus, and they can have like normally they will recover during that period, like after that period. Only in immunocompromised people it causes disease. In developing countries and in socioeconomically disadvantaged population in developed countries usually have like occur like EBV infection occurs during infancy and early childhood. Like mostly their main here point is the people with lower socioeconomic group, they get infected by EBV by early age. Like by if you take in Africa, by 3 years of age, almost all children will be affected by EBV. But in Western time, like it takes by around 80 years, 75% of the population is infected by EBV. By around 25, like the population is like some 93% of 85% of population. Like the development of UV viruses later in developed countries are like with the higher socioeconomic people, like advantaged population. Primary infection during childhood, usually it is asymptomatic or mild, and it is like indistinguishable with other childhood infections. So like mostly it goes as silently in children, but in adolescent adults they can have manifest as like only 30 to 50% of cases. It can have classical triad of fatigue, pharyngitis, general lymphadenopathy. They can have fatigue, pharyngitis, and general lymphadenopathy in 30 to 50% of adults and adolescents. In children, it is asymptomatic. Transmission happens mainly through oral secretions, and maybe by via sexual intercourse also it can happen. EBV starts in oral secretion constantly for more than 6 months after acute infection. If someone is infected by EBV, for 6 months they will be infection, shedding the infection for 6 months continuously, and then intermittently from life, whatever I told, like intermittently they can have reactivation of EBV. They will shedding the virus, but they won't have any symptoms, so they'll be passing from person to person. As many as like 20 to 30%. If you say take any healthy people, if you take 100 healthy people, you can find around 20 to 30% will be shedding the virus, activating the virus at any particular time. Then pathology. Here, virus replicates in oral epithelial cells. From oral epithelial cells, the virus travels to salivary glands. In salivary glands, they also they multiply. From there, they involve B lymphocytes. The virus enters the B lymphocytes. Through B lymphocytes, they travel to lymphoreticular system, that is lymph nodes, liver, and spleen. There, they induce CD8 lymphocyte proliferation. The CD8 lymphocyte proliferation happens to check the viral replication in B lymphocytes. This CD8 lymphocyte proliferation represents atypical lymphocytes seen in EBV, which are like mononuclear lymphocytes, atypical lymphocytes that happens because of the CD8 lymphoproliferation. Then clinical features, whatever, as I said, like most of the primary infection in infants and in children is clinically silent. In older patients, they can have onset can be insidious and vague. Insidious is like very gradual kind of onset, and then vague like the features are like we can't attribute to any other thing. Like very vague. They can tell like there's mild increase in temperature, but we may not record the temperature high. That kind of thing happen. Patient complaints of malaise, fatigue, fever, headache, sore throat, nausea. You can have abdominal pain, myalgia. This generally prodrome lasts for 1 to 2 weeks. These complaints of sore throat and fever gradually increases. So the sore throat and fever complaints gradually increases until they reach the hospital. When you see this generally that during that time, if we examine them, they can have splenic enlargement. Sometimes the patient presents directly with splenic enlargement with features of left upper quadrant discomfort and tenderness they can present. If you see, then they can have splenic enlargement. Then you examine the throat and other things, like in other way, it goes from the spleen, it goes, the diagnosis goes. And then classical physical findings is generalized lymphadenopathy will have splenomegaly and hepatomegaly. They can have on throat examination, they can show pharyngeal inflammation with exudates and petechial junction of soft and hard palate they can have. Maculopapular rash can be seen in 3 to 50% patients. But if they're given ampicillin, antibiotic, ampicillin, amoxicillin during this illness, they can have 30%, they can have rash. This maculopapular rash, this is known as ampicillin rash. EBV is also associated with Guillain-Barré syndrome. Here, this syndrome is characterized by symmetric rash on cheeks with multiple erythematous papules, which may coalesce into plaques persisting 15 to 20 days. These are the tonsils with the membrane formation. These are tonsils, but the white thing you see membrane over the tonsils. This is seen in infection mononucleosis. And then complications. Complications are very rare. Very like here splenic enlargement happens. So with minor trauma also splenic rupture can happen. It can have air obstruction due to enlargement of oropharyngeal lymph tissue. Other complications like meningitis, seizures, ataxia, myocarditis, hemolytic anemia, thrombocytopenia, neutropenia, aplastic anemia, interstitial pneumonia, and pancreatitis can happen. But these complications are little rare. Nothing to worry about these complications. And diagnosis is mostly by clinical and laboratory. Leukocytosis, lymphocytosis, the presence of atypical lymphocytes can be there, and marginal thrombocytopenia with elevated liver enzymes can be there. Pulmonary test is used for screening. This is an heterophilic antibody test. Here, the patients like patient would have produced antibodies against EBV. These antibodies are used to augmented sheep RBC. That is heterophilic antibody test. This pulmonary test is this one. Like if it is a positive, it is a screening. Most of the times it will be positive, but 10% of cases it can miss. Like false and negative, it can give in 10% of the cases. If you want a confirmatory diagnosis, we do IgM antibodies for viral capsid antigen. That is IgM VCA. This confirmatory test for during acute infection. Differential diagnosis are other infectious mononucleus like illnesses. Whatever I told, like cytomegalovirus, hepatitis virus, adenovirus, they can cause a similar illness. So we have to differentiate from other those illnesses. And streptococcal pharyngitis also can present in a similar fashion. We have to differentiate from them. And next important thing is leukemia. We should be able to differentiate from leukemias. Leukemias also we have splenomegaly, lymphadenopathy, and splenomegaly. Splenomegaly, lymphomegaly, and lymphadenopathy. They can present a similar way. Acute leukemia also. So we should be able to differentiate from them. Treatment is here is supportive, rest and symptomatic therapy. Like here, the patient needs rest. They should not strain physically so much with infection mononucleus. They need some rest for a week or so. And strenuous work, we ask them to avoid strenuous works during that time because spleen is enlarged. Even with small traumas, there's chance of spleen rupturing. So we ask them to take rest, bed rest. And symptomatic treatment is like if they have fever, we give antipyretics, paracetamol, and other things. If they have any dehydration, we maintain hydration with IV fluids and other things. And then prednisolone can be used 1 mg per kg per day for 7 days for treating complications like if they have hemolytic anemia, airway obstruction, meningitis, or thrombocytopenia, we can treat them with prednisolone. And sometimes intranasal steroids also can be used. If there is enlargement of adenoids causing nasal obstruction, we can use intranasal steroids. Thank you. And one more thing about EBV is it has got, along with pathogenesis of this thing, it has got oncogenesis also. It can cause cancer also EBV, especially blood cancers, B cell cancers. Actually, Burkitt's lymphoma is one of the most common with EBV. So that we have to oncogenesis is an important thing. Thank you. If you have any doubts, you can ask me. I think the class is a little vast. It's more of a dry subject. Nothing much to explain here. Any doubts, guys? Fine then. Hope you understood the class. Thank you.